You are live. All right, good morning. This is Senate Health and Welfare. It is January 15th, and this morning we're going to look at various bills that are in committee and make decisions about how we're going to move forward on those. But before that, we're going to hear from Joint Fiscal on the provider tax and FMAP. So, Nolan, it is all yours.
Thank you.
We look forward to this. We'll all need it.
Well, thank you. For the record, Noel Lang with the Joint Fiscal Office. The goal of these two very brief presentations is a refresher or just a very high level foundational of FMAP and provider tax. And as you start getting pieces of the budget or start looking at bills that deal with Medicaid, this stuff you'll find is quite helpful and sort of foundational understanding of that stuff. So I'm going to do the FMAP first. So FMAP stands for Federal Medical Assistance Percentage. So just in terms of the state budget context, the total state appropriation is $9.2 billion. Medicaid spending accounts for about a quarter of total state appropriation. That's state and federal. So you can see that Medicaid spending is just that piece is $2.4 billion. Total fiscal year 25 federal funds that we appropriate are $3.2 billion. That's roughly 34% of the total state budget. 40% of that 34%, or 40% of the $3.2 billion, is just Medicaid, our federal dollars for Medicaid. So 40% of all of our federal dollars that come in are through Medicaid. So overall, Medicaid expenditures are about $2.4 billion in fiscal year 25. Medicaid is funded through a combination of state and federal matching. So again, FMAP is the federal government match allowable state. So it's the federal share. So we call it FMAP. You can see that FMAP accounts for 62% of our total Medicaid budget, and the rest are mostly state funds, or mostly general funds, with some other small amount of state funds that are in special funds. But when you do 33 plus 34, 37% are state funds and the rest are federal funds. Most of that blue thing are from our FMAP. There's a small sliver of them that are just federal grants. So most of that's federal matching dollars range between 50% and 90%, depending on the program. So for instance, actually I'll get into the weeds if who falls into what. But on average, it's about 62%.
How does that relate with other states?
Perfect segue to the slide.
Oh, I can't see it.
So FMAP, there's a complicated formula. The federal government tells us every year where FMAP is going to be for the following fiscal year. And they have a formula, which I can't get into the weeds of because I don't know, but basically at the high level, the way it's determined is it's the 3-year average of state per capita personal income compared to the national average. So it's sort of relative to everyone else. So no state can receive less than 50% or more than 83%. So I have here a list of various other states just to give you a sense. So for instance, Mississippi has the highest FMAP. They're at 76.9%. This is for federal fiscal year 2026. Now remember, federal fiscal year is for October, September. Our state fiscal year is July to June. So, but this is their federal fiscal year FMAP. And then for the state, we have to do this whole conversion of how we come up with our state. But this is the federal, and you can see they're at 76.9. And then you can see the states that are at the low, there's the high per capita states: California, Colorado, New Jersey, New York, Massachusetts. And then I just threw in the other New England states just so you can get a sense. So Rhode Island is 57.5, Connecticut, New Hampshire, Massachusetts are all 50. We're at 59.01. Again, this is our federal fiscal year. I'll give you the state fiscal year for conversion. They made to 61.29. Now you'll see arrows next to them, up, down, up, down. That means that their FMAP went up from the previous year or down from the previous year. So it's a cyclical. And I have another slide that shows you how it just sort of fluctuated over time. So this is the fiscally, these are the FMAP for our current fiscal year, for fiscal year 26. The next slide is 27, which we do our budget. So for the current fiscal year, and this is our state, so we convert the federal fiscal year to state fiscal year, and that's what this number is. That's why it doesn't match this number on the previous. When we do our budget, this is the FMAP that we are using. And so we have multiple FMAPs. Our regular FMAP is 58.1 to 41.2 per state. Converted, that means for every dollar, every state dollar we put in, we get $1.43 for a total of $2.43. So that's most of our FMAP. We also have an enhanced FMAP for our children's health insurance. That's roughly 70-30. So again, for every $1 we spend on CHIP, and that's about 4,400 kids, something between 4,500, 4 to 5,000 kids. So every $1 we spend, we get $2.47 from the federal government for a total of $3.47. And then we have our childless new adult. This is the expansion population under the Affordable Care Act. We call them new adults. It's just the category that is named. They're not actually new adults. This is just a category that we've named the time they were new. Anyway, let's just ignore the name. Just know this is the Affordable Care Act expansion population. We get 90-10. Every state gets 90-10 on this particular group. And that's about 41,000 adults who do not have stimulus. Our FMAP went down. So it was 58.81 for fiscal year 27. It went down 58.07. Now that might not seem like a lot. I forget the conversion, but that little drop translates to somewhere between 10 and $15 million of additional state dollars that we have to put in because the federal government's cut back. Now, what I always say is, from this budgetary standpoint, when we see that the FMAP has gone down, we're like, damn, that's really bad for the budget. But if you recall, it's an average of state per capita income relative to the other states. So if our FMAP has gone down, it actually means that it's an indicator that our capita income has actually gone up relative to other states. So it's not a bad thing for the economy and for people, but it's a bad thing for the state budget. It's a kind of a double-edged sword. The other double-edged sword I like to flag for people is, again, so we're getting for every $1 we spend, we're getting $2.38 in services. In times where times are bad, if we're looking to make cuts to programs, for every $1 we cut in Medicaid, we lose $2.38 in services. So it cuts both ways. So now on the flip side, I've heard people say, oh, we're leaving money on the table. Why aren't we putting more money with all this match? And that just comes down to still a dollar out of something else. And it's about priorities. And then also under our global commitment, we do have cap on how much we can spend. But that's a presentation for another day. This shows like how the FMAP has gone up and down over the years. So for instance, you can see where it's gray, it means that this is state share. Where it's white means our state share went down, which means the FMAP went up. So where it's white, it means that the state is paying less. And then where it's gray, state is paying more. And for many, many years, you can see it was kind of cyclical. It was up, it was down, it was up, it was down. And I kind of put these little pieces. So for instance, the 2003, 2004, there was a downturn. And so the federal government did this temporary relief for states. There seems to be, even though it's cyclical, there tends to be sort of a correlation, a lag, but still a correlation when the economy is bad. And then we had all these other things happen. So we had a regular FMAP, and then the American Reinvestment Act during the Great Recession, the states were given additional FMAP to help them, get through the time. And then during the Affordable Care Act, we had the Leahy bump, which was a 1.5% over a short period of time. And then we also got a 6.2% FMAP bump during COVID. So we've also had these, but these trends are the regular base FMAP. And then I had these tiny little dots that show where the bumps were. But the bottom one is just the straight FMAP showing just the trends. Just so you can see it goes up, it goes down, it goes up and it goes down. We've never really gone above, we've never hit 50, we've never really gone below 40. So it seems to be consistent. So that's the FMAP. And the reason I kind of did that was because it blends, there's a relationship between the FMAP conversation and the provider tax conversation. So let me pull up provider taxes. You know, for the senators on my left, they're both on finance and both, we did receive this presentation last week, but
This will make them experts. That we will now have in our committee. We'll test our name.
I like testing memory, but I also feel like you can never hear this stuff too much.
No, you're right.
And there is stuff in HR one, the federal bill that the federal reconciliation bill was passed last year, that has a significant impact on provider taxes, which will have a significant, and I use the word significant because it is big numbers. It will have a big impact on state dollars that will be available to states to use for Medicaid or other. So what are provider taxes? They are healthcare related taxes. And there's a whole list of the specific healthcare providers that can be taxed. That's on the next slide, or it's 1 or 2 slides ahead. Again, as you know, Medicaid is financed through a state federal partnership, and traditionally these dollars have been used to draw Medicaid match. Now, I am caution that because people say, "Oh, we're taking the dollar from this and we're using it for Medicaid." Yes and no. We walk a fine line because this all goes into the general fund. So I always think of the general fund as like a pond, and there's water going into the pond from all various sources, and there's water going out of the pond, all various sources. So water goes into the pond from fees, from other different taxes, as well as provider taxes and others, and going into the same pond. And the money's going out for Medicaid, money's going out for fish and wildlife, money's going out for ag. So I just sort of say, water is not like a pebble. It's just like water. It's very fluid. So on the one hand, we still consider it health related tax, but can't necessarily say that that dollar that's coming from that hospital is going to that service. Sort of fluid. You know what I mean. And then finally, provider taxes. We can't just go ahead and tax these providers with however we want, how much we want. There are limits, there are federal rules around who we can tax and how much we can tax, and the things that we can and cannot do with that money. So they're deposited into the general fund. Provider taxes are a significant amount of the general fund share. When you look at the amount of general fund, they are a big piece of the general fund relative to the total. We just said the whole thing about money going in, money going out, but we're saying you get the drift. It's provider taxes account for or equal to 28% of the general funds that we are using for the Medicaid program, or they are 9% of all funds we take to state and federal. So in short, it's a lot of money, and it's a big percentage relative to the general fund amount that we are using for our Medicaid. You've already been through this, but this is that point about, if you raise this much money, that equivalent can raise even more money. So I'm just skip these and get right to this. So here are some of the rules, federal parameters. So provider taxes, they must be broad-based, which means they must apply across the class of healthcare items provided. So for instance, this is where Jen comes in. I always mix some of these up, but basically I can't say Copley, you're 3%, University of Rome Medical Center, you're 3.5%, Berlin, you're 6%, right? It's like all hospitals are big, the same amount, broad-based. You are applied equally regardless. It must be uniformly applied, which means it has to have the same per bed licensing fee across, same assessment rate, gross. Okay, so that's the one. I always mixed up. This is where Jen usually comes in. She can tell you the difference between broad-based and uniformly applied. Let's mix those two up. But anyway, the point is you can't discriminate. You have to administer these things across the class equally. And then you can't hold providers harmless. So for instance, I can't say, okay, North Country, you've been taxed $1 million. I want to make sure you get $1 million back. The way that you get it back is through your Medicaid utilization. So some hospitals may pay $1 million in provider taxes, but then bill $2 million in Medicaid. Some may bill less, but you can't be like, don't worry, wait, I'm going to make sure you get that money back. Remember that money's coming out and it's being matched and it's going back into the system. this is where things are going to change in 2028. Well, actually, first let me flag the classes. So these are all the 19 federal classes that you can do. So inpatient and outpatient hospital, we just call that the hospital provider tax. That's just one tax. Nursing facilities, that's nursing homes. If it's red, we have it on the books and we tax it. If it's black, we do not tax it. So currently in the books, we have hospitals, we have nursing homes, we have these intermediate care facilities, we have prescription drugs, and we have EMS services. We don't tax any of these other ones. We have looked into doing some of them in the past. And long story short, the juice wasn't worth the squeeze. Implementing provider taxes are very complicated. And sometimes, for instance, we looked into doing dentists about the Chamberlain administration with dentists. Yes, Madam Chair.
So I'm looking at the list. And the question comes up, we're very much interested in acute care services for recovery for substance use disorder, as well as step down, different levels. Are they eligible for provider taxes?
I don't believe they are unless they're owned by a hospital.
Well, we think that, and also if you're acute care.
If you are owned by a hospital, so for instance, physician services is a separate class. We don't tax physician services,
Right.
but if physician services are provided in a hospital, they're captured in the hospital provider tax. So if it's within a hospital, it'll be captured, but that's specific.
Does that include primary care practices that are clinically affiliated with hospitals?
If they're part of the hospital's net patient revenue. If they're part of the hospital's net patient revenue. So if they're part of the network, no, we don't tax the network, but we tax the hospital. They are part of the hospitals, they're capturing the hospital's net patient revenue, it is captured. If it's an affiliate or I couldn't get into the weeds of what.
Okay, but I'm looking at some of these things. We've got outpatient services.
Yeah. I mean, it's a great question, and that gets into the weeds of what is in and what's out. But, but in terms of taxing a new service, in the past, we haven't taxed more services because it was too complicated to do that. However, with HR 1, we cannot tax any new service or increase any rate going forward. It sort of froze everything in time. We did reduce the service about 3 years ago. We were doing home health, and we eliminated the home health provider tax because for many reasons. But under HR 1,
So just a clarification, so that is effective as of now.
yeah. So for instance, I'll bring you to the next slide. So here is who we tax. Here are the rates that we tax about. We can't, ambulance, for instance, hospitals, ambulances are 3.3%. We can't up it to 4%, nor could we go, so you know what, we want to tax dentists now. HR 1 froze everything in place. We no longer can tax a new service, nor can we increase an existing rate. We probably could eliminate a service. I don't see why they would be against that. Or we could probably reduce it, but I think we probably couldn't increase it once we reduce it or eliminate it. That gets into the weeds.
Are you going to talk about the effect of that happening?
I will get to that slide, yeah. So these are all the ones that we currently tax, and here's the revenues we bring in. And you can see hospitals account for 93%. Hospitals account for a big percentage of our spending in our system. They provide a vast amount of services. They get hit the hardest. They spend the most on provider taxing. Nursing homes is a little funky because it's per bed. It doesn't go above the 6%. When this went into effect, nursing home providers were like, it's a lot easier for us to just for you to tax us on a bed for the year than this for a calculator net patient revenue. So that's how it's done. But as long as it stays below the 6% threshold, which it does, their rate's been pretty consistent. Intermediate care facilities, we don't have any anymore. Those are like group homes. We don't actually have any intermediate care facilities, but they're still on the books for some reason. And then pharmacy, we get a 10-cent per script, and then home health for sunset. Just to give you a sense of what other states are doing, in 2004, this is according to Kaiser, 35 states had at least one provider tax. It's by 2024, 49 states and the District of Columbia had at least one provider tax. The most common was nursing homes and hospitals. And then approximately 13 states, including Vermont, had provider taxes greater than 5.5%. And 20 states had provider taxes on hospitals that were lower than 3.5. Now, 6% is the max. You can't go above 6%. And then we have intermediate care facilities. 32 states have those. So this is the impact of HR 1. So what HR 1 does is it phases down the provider tax that expansion states can charge from 6% to 3.5%. So right now, under law, we can't go above 6%. What it's going to do is over time, it's going to reduce the maximum rate by 0.5 per year, starting in 2027. And eventually until it gets to 3.5. So currently we're at 6%, it will go to 3.5. So if you look at all of our provider taxes, the only one that's really impacted are hospitals because they're at 6%. Nursing homes are actually excluded in HR 1, so they don't get they're okay. That particular one was excluded. Ambulances are at 3.3, which is below 3.5. Intermediate care facilities were also excluded. The two of those, I'm not quite sure why, but we don't have any anyway. And our pharmacy again is lower than 3.5. So beginning at 10/1, which is the beginning of fiscal year 28, it started to go down. And as I mentioned, it also prohibits states from enacting any new provider taxes. This is the impact. This is the estimated impact. Now, when you hear from AHS, their numbers are slightly different than mine, but we're consistent. And again, the answer is we just don't know, but they're consistent with ours. So it'll hit us in state fiscal year 28. We'll lose $15 million, and then it compounds over time. Then it'll turn to 35 million, then 57 million. And by the full rollout, by the time it's fully implemented by fiscal year 33, we will have $113 million less in general fund.
That's not quite half, right? From what you're currently are.
It's a little less, but we're from 6% to 3.5%. But what I've also done to nerd out a little bit is, and we're saying, okay, it's based on net patient revenue. And there's a formula for what defines net patient revenue. So I'm assuming our net patient revenue goes up 3% every year. So the base is increasing 3% per year, and you're just decreasing off that base. So that's why the numbers aren't like 15 to 30 then 45. There's a bit of a base increase built in there, which means there's higher revenue, which means you're losing revenue, higher net patient revenue base, which means it's more of a hit. So now again, it's $113 million less that you have to spend on, again, it goes into the general fund. So the levers that the state will have to compensate for that will be to cut services, raise new revenues, find efficiencies, or find money elsewhere in state government. And the answer is you'll be looking at all of those things, assuming you are still here in fiscal year 2033. So, but this is big money. And it doesn't affect us in this fiscal year or even the next. However, legislators should be mindful when they're doing the 27 budget that any expansions that you do in 27 will potentially be on the chopping block down the road. So you have to be mindful, and I'm sure the governor is doing this as well. As you're building the 27 budget, start being mindful of your future down the road of what's going to be available. Rainbows and butterflies? Rainbows and butterflies?
I mean, a lot could change too.
Yeah, a lot could change. But this is the world that we are currently,
Right.
So this becomes our new steady state. This is,
And we are in budget year 27, looking at the 28.
no, we're in 26 looking.
Well, we're in fiscal 26, but we're looking at 27 with the new budget.
We're also looking at 28.
No, well, no,
Yeah.
it's not far away.
I always thought that fighter tax was just a state-owned tax. I didn't realize it was the federal government. So I didn't realize that. I guess that I didn't know federal government.
Yeah, they
The
always
reason
thought
that-
it was such a bad thing that we were doing. Right?
But basically what it was, the federal government said, look, we know you're taxing providers to raise money to pay providers. We're okay with that under these barriers, under these thresholds. Just don't go above 6, and And make sure you're not giving that hospital the exact amount. Like they were like, we know you're doing it, wink, nod, fine. But here are the rules for which you have to operate.
So Nolan, I guess I'm concerned about, because when, God, years ago, when I was on folks, we used to discuss, we cut a deal, federal government.
The global commitment.
It was meant for, it was Medicaid waivers.
Yep.
And there was a couple of them, as I recall.
There were when you were there.
Okay. Things have changed. Yeah,
It used to be choices for care and
Yeah.
global commitment, and now choices for care is part of global commitment.
okay, so I'm concerned about how long that commitment is for.
Yep.
And I would like to see worst case scenario, if you lost that commitment, what would happen?
So you are asking the right question. I have another presentation on that, not today, but this is really important. Global commitment is basically it's the name of the agreement with the federal government for how we administer our Medicaid program. And almost every state has a waiver. We're the only state that operates our whole Medicaid program through that waiver. And the idea behind a waiver basically is that, basically Medicaid is like, there's basic rules of Medicaid. Here's what you can cover, here's what you can't cover, here's how it's reimbursed. And the idea behind a waiver is they're called innovation waivers. It's the idea that when it was created, the states could be innovative. You come up with the same way to operate your same program that meet our guidelines and do not spend any money in the absence, more than it would in the absence of the waiver. Go for it, and here's the agreement. And so we have a lot of things that we use to achieving savings. We can reallocate those money for things that are within the terms and conditions of that waiver, right? And so we operate a lot of our Medicaid and substance use programs and public health and other stuff through that waiver, that in the absence of that waiver, we lose. And we have this thing called investments. And those, again, are things that we can spend dollars on that have been approved by the federal government and get match on. That in the absence of it, we would not be able to get match on. So, and that's somewhere in the ballpark of $150 million.
That's what I was.
Yes, somewhere in that ball. It used to be up as high as 200. It's gone down a little bit because the federal government started ramping down on what could be investment. But in short, the second part of your question is that traditionally waivers are 5 years and renewed for like another 3 years. And we've been renewing global commitment for almost 20 years, right? But with changes, each time we renew it, there's new terms and conditions. But the basic premise, actually, what the program looks like now versus what it looks like when it's actually quite different. But it could evolve to what the needs are of the policymakers and the needs of the citizens. That said, this current waiver expires at the end of calendar year 27. And it will be under this particular administration. And there's a belief that this current federal administration will no longer want to allow us to do global commitment.
That's my point. So I think the finance committee is going to be extremely busy.
Yes. So the other point I want to raise is that when we first did
So
this,
will we. I mean, there's a policy piece of
Yeah.
that in terms of choosing
Which ones?
who is covered. Exactly.
so the global commitment was first passed during George W. Bush. And at that time, to recall, George W. Bush was kind of pushing for federal block grants in Medicaid. This was kind of the closest he came to a federal block grant because it was like, we're going to operate within this specific amount. If we go over that, we'll pay, but we never did. And so they approved it because it fit within the president's philosophy at that time. It can be assumed that this no longer fits within the current administration's philosophy. There is a hope. During this last version of this administration, it also expired and we were able to negotiate, I think, like a 1 or 2 year extension, or there was negotiations were happening during it, but finished during the Biden administration. So it changed once the administration. But anyway, long story short, there's a lot of uncertainty about whether this waiver can be renewed or what it would look like. And not to put words in administrative officials' mouths, but they're not optimistic that what global commitment is now is what it will look like when we renew. And we have to start negotiating with them this year, because it's always like a year process. So we'll start this, and this budget will give authority to the administration to start negotiating, and they will be negotiating through this into next year. So we'll see what that looks like. But Senator Morley, you're asking the right question. So if there's any other more doom and gloom, I've got lots of doom and gloom in my pockets.
I've heard of that.
I'm guaranteed, invite me, I'm guaranteed to bring you right down. That's my My job
Who's
here,
doing the actual negotiating?
HS.
AHS. See, yeah,
So Ashley Berliner,
Yeah.
who I have a lot of confidence in, saying on the record, if you're listening, she's bright, she knows her stuff. I'm confident that her and her team will be, fighting for us.
well, and the decisions that we've made, asking for expansion, have been based on what we need in the state. So, they've been thoughtful requests. Well, see where it goes, and we will. So, thanks for all the cheery news.
You're welcome.
Well, I think it's interesting. We're gonna be losing within the next 5 years, $115 million. No, we just got $195 million. Oh, but it's not replacing this. Completely different, but it looks like a gift. But it's not. We've lost subsidies and we've lost this. So overall, the people who are in greatest need are now in greater need. My. Oh, thank you.
If you need any more bad news, just call me, I'll come running down.
But which category was ended in 23 for provided tax?
You think at home health?
Yeah, thank you,
You're welcome.
Madam.
Jen's gonna boost you back up to be the winner and be the savior. Savior.
We have a couple minutes. Jen, do you want to get started right now or take a quick break? It's up to you. Why don't we get started and then we'll take a little break in the middle of all this. Okay, yes, let me just. So, we put the bills on that we talked about, during committee and now we'll go through and look at what they are and then we can make sort of decisions. This is the first crack at these bills. By no means have we looked at all of them. And, we'll have to have sponsors in to share the reason why they were introduced. That, are we solving problems?
Trying.
Yeah, so that and then, so yeah, Rebecca, Senator White will be in a little bit, but so we'll start out. All right, she's not coming until 10 o'clock. Do you want to start with S-190?
I'm sure anywhere you'd like.
Okay, well, let's do that. We'll skip over Senator White when she comes in.
Okay, I don't know what order you have on your.
Hang on a second. I'll ask Calista. It's a way to see if she's available now.
I don't have a. I can run down to transportation.
No. Okay, now let's just start and she'll pop in and we'll be all set. We're flexible.
All right,
I think.
Madam
A
Chair.
lot of
yeah.
these are my bills and so I'm not going to say anything unless I got it.
Okay, so for the record, Jennifer Carvey, Office of Legislative Counsel. So there was an order on the website, of the bills listed under my name, and the last two are, I think, the ones you have external sponsors for. So if you want to go in that order, we can start with 197, or we can start with 190.
Well, your choice.
Well, I think there's a lot of interest in 190, so let's start with 190.
One night.
Okay. Yeah, there's been committee interesting. This is the one that has revenue face first. And Madam Chair, you'll have to tell me how much detail. I know we're doing more detailed walkthroughs next week.
50,000 feet.
Okay, and maybe we'll just start here with the statement of purpose of the bill as introduced, which is always just the objective summary of what's in it. The bill would set out certain requirements that health insurers and hospitals have to meet to facilitate the Green Mountain Care Board's implementation of reference-based pricing. I'll take at least that. So it requires certain information to be provided as a percentage of Medicare or another benchmark in order for provider contracts entered into on or after October 1st. Yeah.
So FYI for us, a One Foster, a preventive care board will begin at 11:30. And we can ask him questions and Emily Brown as well about reference-based pricing and we'll do a little bit of a dive into what that means. But if I'm gonna ask Jen, maybe kind of the broader perspective of
Okay.
what would that mean if we had reference-based pricing for hospitals?
I'm not sure, what would it mean if we had reference based?
Well, what is reference-based pricing?
Yes, and I think we talked about this a bit when we looked at Act 68, but reference-based pricing is using a particular benchmark. We start by talking about Medicare. There are reasons Medicare might not be appropriate in all instances, but let's say it's Medicare. And the Green Mountain Care Board would set a percentage of Medicare, and in many cases more than 100%. So I think sometimes when you say a percentage of Medicare, it sounds like it's going to be less than 100% of Medicare, but often we're talking about more than 100% of the Medicare reimbursement rate for a particular item or service. And they would set them for each item or service delivered in a Vermont. They're starting with hospitals delivered in a Vermont hospital, and that amount represents the maximum amount that the provider can accept, can get, and take in payment for providing that item or service. And so that allows us to, even if there would otherwise be variation among the payers, it allows us to, at the provider level, to regulate the amount that they're actually getting paid, the amount they're actually receiving from as many of the payers as we can affect. The only one we can't really affect is Medicare. Medicare may end up just being 100% Medicare. And Medicaid is set through its own separate process. But for all other payer types, this is the maximum amount that a provider can get paid for a particular item or service. So we get some predictability and potential cost containment, or at least cost regulation through the board's rate setting authority.
Rather than allowing anyone to charge as much as they want for any
Right.
service. Thank you. Does that help?
Yeah, no, I'm just gonna off.
So, and so, my understanding, you can ask the board more about it, but is that there may not be the same price for the same service at all hospitals
Right.
statewide. There may be reasons based on the mix of the acuity of the patients, the volume of the patients. Various other factors may affect the financial needs of the hospital, resources that it has access to through other state and federal programs. There may be reasons that the board sets the rate differently for a particular hospital, and that kind of gets into their hospital budget processes as well. So they establish the budgets for hospitals, so they have an eye on what the hospital's financial needs and expenses are, and then what services they provide. All of that is under development for it right now. So there are certain requirements in the bill for what hospitals and health insurers have to do so that it can help the board to implement the reference-based pricing, and gives them particular parameters and ways to code and report information so that it can be more easily identified and tracked and compared kind of apples to apples across the different hospitals. And then it allows the board to set kind of a default percentage of Medicare as the ceiling for new codes until the board gets to setting codes for new items and services. Then there is a couple of sections on hospital outsourcing. This is an issue that came particularly to light during the most recent hospital budget processes and the extent to which hospitals are outsourcing clinical services, like emergency medicine, anesthesiology, radiology, laboratory services, and other specialized care to outside entities. So sometimes this is for things like radiology. It might be, and I think my understanding has been going on for quite a while. They might send images to be read by somebody not employed by that hospital. They might contract out that service. But there are others like emergency medicine and anesthesiology that really direct patient care that are increasingly in some hospitals being provided by providers who are not clinicians who are not employed by the hospital. But are employed by contracting, sort of employer contracting or employee contracting services. and sent to Vermont hospitals for some limited period of time, sort of like traveling nurses, but in this case, traveling physicians or others. And so that brought up some issues for the board. Revenue from those outsourced clinical services. I'm going to go through the findings. I think is helpful, Madam Chair, on this piece, just to explain it. So revenue from these outsourced clinical services is not consistently reported in the hospital budget process. The Green Mountain Care Board does not have regulatory oversight. It may be a way that hospitals are getting around some revenue caps that the board has imposed and spending limitations, which can have an impact on budget transparency and accountability. There's also the potential that these outsourced services can operate outside of price controls that the state is trying to put in place, including reference-based pricing. There's potential for patient-facing network adequacy issues, surprise medical bills, and inconsistent access to the financial assistance policies that otherwise apply at hospitals when they get care from outsourcing providers. So this enacts a new section on hospital outsourcing, and it gives the purpose, the few purposes, bringing all hospital affiliated revenue within the purview of the Green Mountain Care Board's regulatory authority, ensuring that reference-based pricing applies to outsourced services, and applying network adequacy requirements and billing protections to protect patients and can ensure access to the required financial assistance policies.
So, so that would, having that capacity then will do two things. One, it'll keep it in the provider tax umbrella.
Right, so I think that comes up in the
It'll help oversee rates in a way that is equitable rather than having one part hospital here and the other.
Can you give examples of the outpatient services, or will you do that when you present?
What is it?
Some examples of this outsourcing.
I think the board can give you examples of what came up during.
We could do that. I remember during the Springfield bankruptcy, that their emergency room services were being provided by a company in Chester, Vermont.
Yeah.
I assume that's an office. So I assume they were one that was outsourcing.
Yes, often these are national, external to Vermont-based entities that employ the clinicians and send them on sort of rotations to different states. All right, so creates a new section and kind of defines what we mean by outsourcing and outsourced services and what we don't mean. It would require revenue from outsourced services to be included in hospital net patient revenue limits, commercial rate limits, operating expense limits, and other hospital budget guidance set limitations from the board. Specifies that the board's rate setting authority, including reference-based pricing and global hospital budgets, will apply to outsourced services. Deems revenue generated by outsourced services delivered in a hospital-owned facility as part of the net patient revenue of the hospital for purposes of the hospital provider tax. So that's of particular interest to Senator Cummings, and other applicable state assessments. That was another piece as well, as that revenue has not been, our understanding has not been included in the hospital net patient revenue for purposes of the provider tax. And then there is some consumer protection language about ensuring continuity of coverage. There's another piece that came up, is that a clinician who is not employed by the hospital may not be there the next time a patient goes in for services. So there may be some issues with continuity of coverage and preventing surprise medical bills. This makes the hospital responsible for billing the patient for health insurance for all outsourced services delivered to a patient by a contracted provider who would otherwise be out of network. So that was an issue that came up, is that somebody could be receiving services in the hospital from a provider who turns out to be out of network under their insurance plan because they're not employed by the hospital where the services are being delivered. Minimizing billing complexity and applying hospital financial assistance policies. Section 4 and just add some conforming language to a couple of sections 4 and 5 to a couple of other sections. So the financial assistance policies for large healthcare facilities with some parameters in statute. And this specifies that financial assistance policy would apply to outsourced services. And similarly, in section 5, adding to the definition of net patient revenues for provider tax purposes to specify that it includes outsourced services delivered at the hospital. Section 6 repeals some language about healthcare professional bargaining groups, recognizing them and authorizing them. That happens in 4 different sections. So this is just a reference to them as part of a definition of payment reform in the Green Care Board statutes. And similarly, in the rate setting, Green Care Board statutes, a reference to healthcare provider bargaining groups. And then it repeals, section 8 repeals the bargaining groups statute. We talked to the board about the rationale.
I think some of the bargaining groups will be interested in testifying too.
I don't know how many there are any
Who's left?
I don't know if there are any, I mean, that, I think it was contemplated and maybe used, on a limited basis at one point, but I'm not, there may be some.
There was a big deal about getting it in statute.
I'm not specifically about that.
Okay.
This clarifies or cleans up some language about the Green Care Board appeals process, including, I think the board does not particularly have an administrative appeals process. Really the result of any final order from the board, final action order or determination is appealable to the Vermont Supreme Court. Providing some clarity on that, the lack of administrative appeals process. Hospital audits, there's some additional language added to the Green Mountain Care Board hospital budget review authority, allowing the Green Mountain Care Board to conduct investigations and examinations, including audits as needed, retain others, and require a hospital that's subject to an investigation or examination to pay the reasonable costs and expenses of that investigation or examination. Section 11 directs the Green Mountain Care Board to, in addition to an existing price transparency dashboard, to develop and maintain a public interactive tool with information on health system performance, including hospital prices relative to Medicare rates, and able to be sorted and have it be updated at least quarterly. And section 12 says they only have to go ahead with that. I think this was a piece that was requested as part of the, may have been in the Rural Health Transformation Grant application. So it'd be helpful to understand if that has been deemed to be a permissible use, but it only if the board receives sufficient funding from the federal government or another source to create that health system performance tool. So that's actually, that's act, or
We don't want an unfunded mandate.
right, exactly. Exactly what it is saying, only if there's funding, right? So that's S-190.
Questions, that's a lot here. But this is a really important bill. There's some sections that probably should be considered fairly quickly. And I know I think we all identified this as important when we went through the list, so that's good. And so we'll have testimony specifically on the bill. When Owen Foster and Emily Brown in today, it's really more about an introduction to who they are and what they're doing. And we'll ask them to come in at some point and talk about the bill and give us some details. Any questions for Jen? Good. Okay.
All right, terrific. Next we have, well, let's see, we can have whatever you want. Next we do S-197.
Yeah.
Yes.
Oh,
S-197. Introduced by some members of this committee. And others, this is an act relating to establishing a primary care payment reform program. And so it starts off with some legislative intent. about investing in primary care by establishing a streamlined primary care payment system that will promote the public good by increasing access to primary care in order to improve the health of Vermonters and reduce healthcare system costs. So it creates a new.
Can I say one thing? So within this, I was thinking about how to provide, equal pay for equal work, equitable reimbursement overall. And then as part of that, some alignment of reimbursement or amount of funds that primary care folks can accept through public and private insurance. So once we have some alignment of codes and payment, then we begin to provide a system of care that will build the workforce in our more rural areas, because we're losing primary care big time. So a lot of the motivation here is to look at how we can improve the rate of that primary care doc or provider can accept anywhere in the state, and then looking at those primary care offices, whether they're affiliated with a hospital, whether they're independent, and so on. So just for me, that's really important. And it's also important because once you have a robust primary care program across the state, including our Blueprint program, then you have a prevention program that lowers costs later on by reducing chronic care problems. So we've seen that already with Blueprint, but we need to ensure that these primary care folks can stay in place and we can add more. Not a difficult concept, I think. Just the weeds get problematic. I'm still working on it. We're going to work hard on this. Maybe we want to.
Right. So this bill directs the Department of Vermont Health Access in coordination and consultation with others to develop and implement a primary care payment reform program. Really should restate some of that intent. It will be initially voluntary, but pretty quickly become mandatory for primary care practices. And you'll see some more provisions developing some of this, but basically the funding would be a portion of premiums from commercial health insurance, premium equivalents from other payers. So there's a voluntary outreach to the self-funded employers who we don't have control over, so we don't have authority, so we can't tell them they have to participate, but we can invite them to participate and either can explain the benefits. And then trying to the extent permitted by law, waivers, etc., trying to get money from Medicare and Medicaid. And then beginning in 2028, all practices would be in. So the idea is that the program would collect and aggregate the money from all the participating payers and would provide a per member per month, so capitated at per person per member per month payment to each participating primary care practice that would cover all of the routine primary care needs of attributed patients who are covered by participating plans with nothing out of pocket from the patient. So a lump sum would be provided to the practice for each participating, each attributed patient whose insurance or other payer is participating, and that would cover all of their healthcare needs, nothing else out of their pocket for their primary care needs. For the month.
These are independent primary care practices. Is that
This would be, this would be both. This would be part of the language at the end you'll see is rulemaking, and part of the rulemaking is determining which primary care practices are eligible. So I think some of this be, but you can be more specific if you take up the bill. And then there's some provisions around minimizing the program's administrative burdens. So trying not to put too many new administrative burdens from this program on providers. And this directs the program to establish some, or allows it to establish some quality measures, but put some limits on how those can be applied. There are some other goals around reducing administrative tasks and the amount of time that providers have to perform administrative tasks and the additional staff they need for that. directs the department to adopt a risk-adjusted model for practices so that can reflect the mix of patients that they have. So there may be areas that are needier than others or have sicker patients that might need higher payment amounts. Try not to go through these into the details yet. And take this up, directs the department to operate a payment pool that would collect all the money coming in for the program for the various payers and then determine the per capita per member per month amounts and distribute funds to the practices. Here's where it directs DVHA to adopt rules, including determining the scope of services that would be included in the capitated rate. So kind of what constitutes the routine care that would be included and which practices are eligible. And then some more information about practice participation requirements and other administrative aspects, risk adjusted allocation model, operation of payment pool, program parameters that try to avoid having practices turn away patients or otherwise avoid high risk patients or otherwise engage in adverse selection. So you can't try to sort of cherry pick patients to have a healthier patient base so that less money is needed to provide the services. Defining direct and indirect spending, benchmarks for determining program performance. Subsection F directs the Agency of Human Services or Agreement Care Board or both to negotiate with the federal government to try to get Medicare participation. And also here's where it directs them to conduct outreach to self-funded non-governmental employer-sponsored plans to try to get their voluntary participation. Try to get them to pay in amounts that make sense. Do you want me to pause here for a moment?
Yeah, let's do that, and we'll turn to
Senator White.
Senator White.
Oh,
here.
we're trying to write you early. We are ready whenever you are. So
All we have to do is remember the number of the bill as 163. And so this
early, great.
well, no, you're just fine, and we have not addressed the bill as yet. But it is about a advanced practice nurse, registered nurses in hospital care. And so Senator White, we're glad you're here
Well,
again.
yes, exactly. Thank you, Madam
Great.
Chair. For the record, I'm Rebecca White and I'm the Windsor County State Senator. And this bill came to me largely because I live in Hartford. And if you live in Hartford, you're either a nurse or you're not adjunct faculty at Dartmouth. So I get a lot of nurses in my community. All the doctors live in Norwich and Hanover. So this bill is very important to me because a lot of my neighbors are the ones who would be impacted by it. So I am not on the healthcare committee. I'm not familiar necessarily with the ordering of bedside physicians, but generally what this bill does is under current law, only physicians are recognized as eligible to serve as the attendee of record for hospitalized patients. This restriction is inconsistent generally with the scope of practice that Vermont is granted to advanced practice RNs, or I'm going to say APRN from now on, just to make it even more confusing. Those folks who are authorized to independently diagnose, prescribe, and manage patient care across all those settings. This doesn't expand the scope of the practice of the APRNs who already manage that inpatient care. Rather, APRNs in Vermont hospitals do already admit patients, write orders, coordinate treatment plans, and communicate with families. And often they do serve as the primary provider of record at the bedside. So this is really trying, in my opinion, to right size what we have on the books when it comes to APRNs. And that's all the information I really can provide you on it. So if you want to grill me, I will defer to friends in the room.
You have friends in the room?
I'm hoping the legislative counselor will be my friend in the room to explain what the bill functionally does in the
Well,
healthcare
no,
setting.
we're appreciative that you brought it in, and we really like to have bills that come from people who are boots on the ground and working in the healthcare world. So this is one of them, and I hope we'll have some recommendations for folks who might testify
Yes.
on this, and I'm sure there'll be others who want to join in on this.
Would it be appropriate for me to email your committee assistant with a
That would
list of
be
like?
terrific. that would be terrific. I know you're always very responsive to our needs. Questions for Senator White? You have some really good neighbors. Thank you.
Yes.
Okay,
Thanks for reviewing the bill and good luck in here.
thank you.
Thank you.
We need
Very
all the
back
luck
to
we can get.
transportation. Yeah,
Is that your cell phone?
it is.
Darn.
He's good. Good addition. Both of them.
Yeah. Okay, thanks. So Jen, here we are.
Yes, would you like to go back to primary care or would you like to talk about the bill you just heard about?
Let's just zip through the one that it's not a long bill, so.
The one you just heard about?
Yeah, so why don't we?
Yep.
Finish off that.
Well, that one. That's moving 53, yes. Great. Again, Jen Carvey from the Office of Legislative Counsel. This is S-163. And it's entitled "An Activating to the Role of Advanced Practice Registered Nurses in Hospital Care." And as Senator White said, there are in particular a few places in statute where the language only speaks to physicians and does not recognize that an APRN is qualified under the law to provide services. So first, we are in the hospital patient bill of rights. This is just numerically, I went through in numerical order in the statute. So we're in a chapter on bill of rights for hospital patients, and adding a definition of advanced practice registered nurse or APRN. Yes.
There's advanced practice nurse and there's physicians assistant,
Physician assistant.
who essentially do this.
They do similar things. Their scope of practice is not the same and their independence is not the same under our statutes.
Okay, so I don't want to do this and then next year find the.
I think it is different.
Okay.
I mean, there may be, you may hear from the advocates for physician assistants if they believe this is appropriate for them as well. And, you know, if you'll want to hear from OPR, I did check in with OPR on this bill to make sure that this was within the existing scope of practice for APRN, so there wouldn't be surprises for the sponsor if the bill was introduced, to have OPR come in and say no. And they said, I'll let them speak for themselves, but they indicated to me that this was consistent and appropriate. So we have, oh, yes.
I'm not an attorney. And when a patient is in the care, who has the legal responsibility? Is it the doctor? In terms of setting that patient's care? And what I'm wondering here is if in fact we give more authority to the nurses, which I'm not opposed to, my mother was a nurse. But how does that work? Because if in fact legally the doctor in charge of that patient has the legal responsibility, how can that authority kind of be transferred, or how does that work?
So I'll say a couple of things. One, we'll look at the language because it's narrower than that, but generally under, existing patient care, I think whoever is the clinician of record who is treating the patient has the responsibility or the legal liability if they do not practice in accordance with the prevailing standards. So you could have a patient being treated by a number of providers with different license types. And if something were to go poorly in a way that was legally actionable, they could have a claim against several different providers and the hospital itself. So I don't think this doesn't change anything about liability, but because we're talking specifically about advanced practice registered nurses, which is a subset of registered nurses who have additional education and training, they do have a larger scope of practice and are able to be the one treating the patient without involvement of the physician. I don't think it applies to all specialties necessarily, so there may be some that are not within the scope of practice for an APRN and are for a physician. But the scope of this bill is really looking at a couple of very narrow circumstances. And if you want more than that, then we will bring in other people because
we'll be bringing in other people. We'll
right
bring in
along, I don't have.
OPR, that's not about scope, but it's that.
All right, so let me share. So first we are in the, as I said, the Bill of Rights for hospital patients, and there is a long list and statute of rights that hospital patients have regarding their care and access to information and who can be, who can receive information about their care or be present in the room. And so we can look at that separately when we look at this bill, if that's helpful. But the first thing we do here is add definitions of advanced practice registered nurse, which is someone who is licensed under this APRN subchapter in the nursing statutes. And I've changed person to individual just because person in Title I for all of the statutes is both individuals and corporations and partnerships and entities. So in this case, patient is always going to be an individual. And then a physician, we have two different types of licenses for physicians. They can be an MD, which is an allopathic physician. What you may be more useful who goes to a medical school like what we have at University of Vermont Marner College of Medicine. And then there's also doctors of osteopathic physicians who are the same scope of practice, but have slightly different training and different.
So we have a DO school in New England, at the New England College in Bedford.
Yes, my daughter went there.
Oh, perfect.
Not as a deal.
Oh,
Sorry about marine biology.
so here we are in section 2 is opening up the patient's Bill of Rights itself. I went through and made some just non-gendered language or change it to take out the gendering. We're trying to get rid of gender at all and just go with non-gendered language like the patient. And so in existing law, it says the patient shall have an attending physician who is responsible for coordinating the patient's care. Here's a place where it may be an APRN who is responsible for coordinating their care. And then this does add in, because of APRN, so this may go to some of your question, the physician consultation and support shall be available to an attending APRN at all times in accordance with applicable standards of practice and regulatory requirements. So the scope of practice is not the same, but maybe the APRN who is the attending. And then adding in everywhere we talk about physicians, adding in APRNs, and again, this non-gender language is the other change throughout. And then subsection B, existing law says that failure to comply with any provision of the section can be the basis for disciplinary action against a physician. And this one is a little out of date anyway. It only refers to a physician under the Medical Doctor Board of Medical Practice chapter and not the chapter 33 entitled 26, which is the osteopathic physicians who are regulated by the Office of Professional Regulation. And then also adding in the APRN, and that a complaint may be filed with the Board of Medical Practice or Office of Professional Regulation based on the license held by the practitioner. And then adding in OPR, Office of Professional Regulation, a couple of other places as well. And then section 3 deals with hospital licensure. So shifting out of the hospital patient Bill of Rights into hospital licensure. The Department of Health is the licensing agency that issues hospital licenses. Hospitals have to meet certain minimum standards. And so under existing law, it says all patients admitted to the hospital shall be under the care of a state registered and licensed practicing physician as defined by the laws of the state. Here, this would change to a physician licensed under either of those two physician licensing statutes or an APRN. And then adding APRNs in another place in here that refers specifically to an attending physician. And the act will take effect on passage.
Okay. So, I mean, we can pick this one up. We can hear from the Department of Health, Board of Medical Practice, OPR, for the regulatory pieces, and then from the Nurses Association and the APRN folks. I'm not thinking that it will be a long, protracted process, but keep your fingers crossed. it doesn't sound like, I mean, it's not an expansion of scope of practice. That's where it gets difficult. And, so I think,
Right, it's authorizing a role that is not currently available to APRNs because it specifies physician, but it is not expanding the scope of what they are permitted to do under their license.
yes, that's an important point. That's a question you were raising. Yeah.
Do we know what other states do with this?
We'll find out.
We'll find out.
We'll find out.
What bill are we going back to?
We're going back to 197.
Okay.
Find that one and we will just briefly recap what we have been. Right. So just reorienting ourselves a little bit. This is the primary care payment reform, directing Department of Vermont Health Access to develop and implement first voluntary, then mandatory participation by primary care practices. We would get a per member per month payment to provide care. So we were on page 7, and this is looking at something that has been talked about in this committee a number of times over the last several years, which is trying to increase the proportion of healthcare spending that is spent on primary care. So not increasing the overall amount of spending, but just shifting the allocation so that more of that 100% of spending is on primary care. And so this language says that implementation of this primary care payment reform program needs to increase the proportion of total annual healthcare spending in Vermont that is on primary care, starting with a target of 15% by January 1st of 2029, maybe increasing that more in the future, but also specifying that this increased spending for primary care shall not increase total healthcare spending, just looking to reallocate within existing or potentially even lesser funds.
That's a really important distinction. So thank you for that. What's the percentage now?
Depends on the payer referenced in here in 2020, or I think
Was it
2019.
2018 and 19?
2019 and it was
And we had
submitted
one
in
in 18, right?
2019 and it was submitted in 2020, I believe. That looked at it and, Medicaid was something in the 20s. Some of the private ones were more in the upper, I don't even know if it was 13. That might have been overall, might have been 12%, but I think some of the commercial was at or around 10%. I think Medicare was lower as well. So Medicaid was definitely the highest, definitely at that time had the highest. It would be interesting to know, and I think some of this may direct.
So just to interject, the
Well-
pandemic got in the way a lot.
Yes.
Yeah. Yeah.
Go ahead.
Sorry. I like this. I don't know why, but it's always interesting to compare us to other states. Is that information out there?
At the time,
Get it? Okay.
right, at the time that Vermont's report was done, it was looking at some work being done in Rhode Island and at least 1 or 2 other states.
Yeah.
That were also targeting a percentage and looking at where they were in meeting that. And so I don't know if other states have been continuing with that work, if those states have been continuing with that work, but this may be something that some of the state agencies and or advocates have been tracking.
Massachusetts grants.
No, might have been
Also did a whole lot of work in Rhode Island on this.
represent.
What you see this like
New representative.
Who?
Herb Olson represent.
Oh, yeah, her, right.
Representative.
Representing Olson now. It has got his head in it. I know.
Yes, he
Well,
was.
good.
He
Oh,
went,
okay.
he went from here.
He was at Wish
Ledge Council.
He was Ledge Council before I got here.
Yeah, I worked with him.
Yeah.
And then he was at Fishka, and then he went, he
Yeah.
became I think the commissioner of insurance, or was high up in the commissioner's office in Rhode Island.
Mm.
And he has a somewhat similar bill to this, and that was just introduced in the House. I think it's H680. So,
When I talked with him, he came in and we were talking about how to coordinate a little bit. And so we're starting with the bill here and then the House will pick it up over there. So his work will be, part of it. So we'll all be working together on this one.
and there is a reference in here on page 8 to that 2020 report determining the proportion of healthcare spending in Vermont allocated to primary care. That was in accordance with the 2019 Act. So we can help you find that and give those.
Sorry, I'm sorry to interrupt. That was not appropriate. We have this bill, we have this report can we make sure we get it up on?
Yes, that's what I was just saying, is
Yeah.
I can look it up
Yeah,
and send it to
I
you.
had that.
That's great.
Super.
Will you post, will you email me or not?
Yeah, we
We're
were
about to
really,
do several others.
we worked really hard on this in the, then, and then we got put on the telephone and, Zoom. So,
All right, section 3 moves into some implementation pieces and reports. It requires Viva to start operating the primary care payment reform program by July 1st of 2027. As I mentioned, participation is voluntary to begin with, but by January 1st, 2028, all primary care practices in the state shall be participating. By December 15th of this year, so just before the next session, DIVA and the Medicare Board would report to this committee and others about progress in establishing the program and its timeline for implementation and options for revenue sources and mechanisms, and for expanding the program not later than January 1st, 2028 to any patient of a participating practice, regardless of their health coverage or coverage status. So it wouldn't matter if your payer would participate or not. All patients would be included. Section 4 calls for an update of a past report, a couple of past reports on the clinician landscape. So how Vermont clinicians are feeling about practicing medicine in this state. By January 1st of next year, the board will report an updated version of its 2017 Vermont Clinician Landscape Study to show the current climate among practicing clinicians, and an updated version of the board's previous reporting on site-neutral reimbursements. And it mentions a couple of acts that have been looking at that, including the current state of reimbursement differentials based on practice setting and ownership type, and anything that's happened since 2017 toward achieving site-neutral reimbursements. There is some language in the bill introduced in the House, H 585, that is looking at implementing site-neutral reimbursements as well. Section 5 requires the Agency of Human Services to report by next January, consulting with others, on ways to accelerate the appropriate transition of patients away from hospital care and toward care in a community setting when that's appropriate, and include opportunities to use community health teams through the blueprint to coordinate patient care transitions. Section 6 would be a report from the Green Mountain Care Board in collaboration with others, considering the existing regulatory structures for access to information to VCures, which is our all payer claims or most payer claims now database. That's the Vermont Healthcare Uniform Reporting and Evaluation System, and the Vermont Uniform Hospital Discharge Data System, BUDS. So we have VCures and BUDS. Just looking at ways to increase access to the Vermont Program for Quality in Healthcare, to that information, and the board, in consultation with VPQHC, the Vermont Program for Quality in Healthcare, also recommend any modifications to statute or current practice help make sure that VPQHC's expenses are billed back. There is an existing bill back provision from VPQHC that sounds like there may be some inconsistency in how that's being implemented. So that report, again, January 15th. Section 7 directs the Office of the State Treasurer and AHS to collaborate with other northeastern states to look at establishing a regional universal primary care program that would be available to all residents of the member states. And has the treasurer reporting by January 15th of next year about their outreach efforts, interest from other northeastern states, and any legal or regulatory obstacles they have identified. Finally, Section 8 removes the sunset on a loan repayment program or scholarship program for medical students who commit to going into primary care in Vermont. That language is, that program was set up in 2021 and is due to expire or to be repealed at the end of this fiscal year. So this would remove that sunset and keep that program ongoing. And the act will take effect on passage. That's what they.
Go ahead.
I may be putting the cart for the horse, but we may not be able to answer this, but I'm thinking a lot of these bills will have an effect on hospital transformation and possibly strategic planning and the rural health grant and all of like, is there a system to make sure all this work gets?
Right, so beginning with this one, with primary care, remember, we have the primary care advisory board, and I consulted with them in helping put this together. And they are working directly with the group that's working with AHS on transformation.
Okay.
A big chunk of transformation is getting primary care in the rural parts of the state and keeping folks where they should be, so we don't shut down the primary care in Waterville.
Right.
Yeah, so yes, it's coordinated. It will be coordinated. It has to be. This will help with that transformation process. Yeah, it should help. Yeah, good question, really.
Ready for another one? We're halfway through our bills, but the rest of them.
Can we take a short break? Let's take a step. Yes.
I don't get stop talking.
We'll go off live.
If you look great.
Break, 6-7 minutes, go back, somewhere around 10:30, that would be good.
Cool. Thank you.